coordinators, Professor Padma Srivastava, who is the Head of Department Neurology and Chief of Neurosciences Center at All India Institute of Medical Sciences, New Delhi, and Professor Vivek Lal, who is the Head of Department of Neurology at PGI Chandigarh, to kickstart today's conference. I think both need no introduction on this platform. They are iconic figures in their respective fields and in the field of clinical neurology, and they have shaped the careers of many successful young neurologists in our country. Not only this, both are known for their love and affection for their residents and patients alike. I hereby invite Professor Padma Srivastava, followed by Professor Vivek Lal, to say a few words.
Thank you, Anu. So, girls and boys, welcome. So this year's virtual meeting has a history, and I'm talking on behalf of my co-host, Professor Vivek Lal, who's head of department of PGI, who also happens to be one of my closest friends in the universe. So therefore, we would be speaking the same language. Now, when we envision this, as I said before, these two institutes have been thought to be citadels of excellence, not because of me, not because of Vivek, not because of anyone else, because of our forefathers who've been really the icons. Anu, they were the icons. We are trying to emulate them. And as part of the exercise of the citadels of excellence, it's important to build these two pillars. And I always call them the cogent twin pillars. There's good clinical practice, there's sound science. And so that's based upon, yes, this, humongous knowledge you have on the web, you read, you amass, but then there's something called bedside. There's a clinical practice. There's a clinical neurologist, and there's bedside neurology, which makes you a good human being neurologist, which I think is, unfortunately, because of COVID times for the last 8-9 months, our newest inductees, 6 months old, 1 year, I think they're more COVID experts than doing neurology. And that's an unfortunate thing across the world today. So how do you bridge this? So we thought that this time, let it be a more democratic virtual conference. We have a deluge of webinars. There's no limitation. I mean, there's that it's raining webinars, but we want it to be different. And as an academic program, which was said on Twitter, Vivek had said it's for the residents, by the residents, of the residents, so that they're inclusive, they're involved in not just amassing knowledge, but also in application in the clinical practice. So, and that happens only when you have a debate and you actually debate upon the nuances and in between the lines and think out of the box. So I hope if that could be delivered as a message at the end of this exercise, it is one goal met. So with this, I hand it over to Vivek, who would probably talk more sense than me. Vivek, please.
No, that's okay. Thank you so much, Professor Padma. And it's a privilege to be called your friend, I'll say. Really, it's an honor. It's a privilege, of course. And I think he said what we both think alike. I mean, we both think alike. That's for sure. We have our residents. We want them to be everywhere. We want them to be pole stars of neurology. We want them to outshine their American, their UK, their Australian counterparts. We just want them to be on top of the world. And so we thought that the best way to do it is this time we have a purely, resident focused program, a clinical program, so that you can hone your clinical skills and to harness and exploit technology. That is the basic purpose of this AIIMS-PGI meet. We have it every year. This time it is AIIMS. Next time it will be PGI. Unfortunately, because of COVID, it had to be postponed. But thank you, Professor Padma, and your colleagues for finally, getting it on air. That's important that we continue this process. We should not have a break. And it's also important that we continue to discuss topics which are of tremendous relevance to residents and consultants alike. Latest cutting edge technology, latest discussions, so that we can get the best of both. It's important that we integrate technology in clinical medicine. because if we integrate both properly, we will achieve an optimum level of medical care for our patients, which is the purpose of this conference. You enjoy medicine more when you are thinking. You enjoy medicine more when you are awake. Now, when are you awake? When you are thinking. You enjoy medicine more, you enjoy neurology more when you are conscious of what you have to make of the data provided to you. And that is how we intend to shape this entire program over the next 7 days. Anu is at the helm of affairs. She's been anchoring the program and she's done a fantastic job. Anu, congratulations. You really deserve kudos for what you have shaped and scripted. God bless you. God bless the program. Over to you to start. Thank you.
Yeah. Before we start off, Anu, I forgot to add that you know, the whole credit of scripting and the entire thing has been done by Anu and Vishnu. Incidentally, both are from PGI and I hijacked them both, and I'm so happy. Thank you, Vivek.
Okay.
Okay.
Yeah.
Right.
Thank you, ma'am. Thank you, sir, for the kind and encouraging words. So today we will have the program run by the team of our young budding neurologists. An hour back, we had a trial run and I could see their faces beaming with enthusiasm. So let me introduce to you our session coordinators. And these 4 budding young neurologists will take you through the entire week's program. So we have with us Dr. Snigdha, Dr. Priyanka. Dr. Snigdha is senior resident at AIIMS New Delhi, and Dr. Priyanka is also from AIIMS New Delhi. From PGI Chandigarh, we have Dr. Dipendra Singh and Dr. Anand Keshav. So for today's sessions, Dr. Snigdha and Dr. Dipendra will be teaming up. Dr. Snigdha will be taking up the session coordination, and Dr. Dipendra will be organizing the question and answer session. And tomorrow, Dr. Priyanka and Dr. Anand will take over. So with this, I hand over the proceedings to Dr. Snigdha.
Thank you, ma'am. Good evening, respected faculty, distinguished delegates, and all my fellow residents. We will be moving forward to the today's session with the first talk. It's my privilege to introduce Professor M.V.Padma Srivastava, Professor and Head of the Department of Neurology, AIIMS New Delhi. Madam is a Padma Shri awardee by Government of India in the year 2016. She had initiated and is in charge of the thrombolysis program in AIIMS, and she has over 200 publications and several projects on stroke, including acute treatment strategies, restorative therapies, and post-stroke epilepsy, stroke in young, and functional imaging in stroke. Professor M.V.Padma is also on board for the National Stroke Surveillance Program, Nodal Officer for the Stroke Program for Government of India, and is the past president of the Indian Stroke Association. Madam has a special interest in stroke and multiple sclerosis. With this long list of achievements, I would like to invite Professor M.V.Padma Srivastava for topic for intracranial atherosclerotic disease and management issues.
Thank you, Snigdha. Can I share my screen now?
Yes, ma'am. I am stopped.
Yeah, you log off. Is it on? Is it on? Okay. All right. So, good evening again. Now we start off with intracranial atherosclerotic disease, and I should say ICAT, and I shouldn't be talking about atherosclerosis. Let's talk about beyond the pierce of the internal carotid artery beyond the segment of C2 inside the brain, or in the vertebral artery after they enter the foramen magnum and have they pierced the V4 segment. So the V4 segment and internal would be the intracranial part of the vertebrobaselar circulation, and ICA is below, beyond the C2 segment. So that's what we call as intracranial arteries. And why do we have to talk about it? The ischemic stroke subtype. You have 10% of all our ischemic subtypes. 20% is the reason for stroke in an ischemic subtype, a large artery, in which you have predominantly intracranial part of a large artery disease in our part of the world and the Far East, and also in certain ethnic populations such as the Africans and Hispanics. However, you have the Western population wherein the intracranial large artery pathology is much, much less as compared to this part. And I must tell you an interesting thing here, which is actually doesn't go down in the literature so much, is Professor Call's description. He called it the Indian pattern of atherosclerosis, wherein we not only have a significant intracranial pathology, we also have a significant extracranial pathology. So we also have the extracranial, the typical carotid artery stenosis, and we also have a significant intracranial atherosclerotic disease. So that he called it as an Indian pattern. So we are somewhere in between the Far East, like China or Japan, and the Caucasian population. So we have some epidemiological studies which have documented that. We have one study from Asia said which is 50%, and from China nearly 40%. And as we said before, it's much less than the Caucasian population. And why do we need to talk about this? Because it is the Asians, the Hispanics, and the South Americans and the Africans who make up 70% of the world population. Therefore, it's an extremely important aspect in terms of stroke prevention, especially in the secondary stroke prevention. So what are the quintessential questions that we would like to answer at the end of the talk? Now, what are these differences due to? Well, we would like to understand them. Some of them is probably because of, there's some literature which says that it's maybe because of the risk factors, the genetic factors, the lifestyle, and also there's some recent literature about pollution. I'll come to that. And the more important thing that as clinician we would all be interested is in stroke prophylaxis and also in the stroke management, which includes, of course, the classic antithrombotic, what's the role of anticoagulation, and going beyond the medical management, what are the avenues we have and what does the levels of evidence say. So why is that the South and the East so very prone to this? One, as we said, there are a lot of risk factors. If you look at the African Americans, they do have a resistant hypertension. They have more accelerated hypertension. They're resistant to a lot of antihypertensive agents for reasons more than one. Their obesity is different, just like even in India, the pattern of obesity would be different. The genetic predisposition, there's a large amount of data which is coming from South India, especially the group of Munshi and Professor Kaul. Now, that group is actually split now, but then we do have a lot of, a bunch of genes which have been shown to be associated with a greater predilection of the involvement of intracranial disease. And so also we have others, but then, how does it translate to a bench-size medicine is difficult at this point of time. The environmental factors are very interesting. There's recent literature which is coming up that the exposure to certain particulate matter, the PM 2.5 and even less, is somehow linked to the development of an intracranial pathology. So is that so? That is that or, geographically we are more prone to pollution and that's the reason we have more ICAT. No level of evidence to say that, but this is an interesting aspect which is coming up. So as it stands, the risk factors include the age, which is omnipresent. You have hypertension, diabetes, hyperlipidemia, your metabolic syndrome, smoking, lifestyle. We also have certain biomarkers such as increase circulating apolipoprotein BA1A and decrease in serum adiponectin and increase in little protein, the lipoprotein little a. The mechanisms of stroke in intracranial arteriopathies are interesting. And this calls for how you have to approach managing an individual patient. And this has a translation to the precise and personalized medicine. And that would actually be my last slide after we go through all of that. And that's the reason why one glove fit all approach would never work. And that's also the reason why we have so much of controversy as to how to manage a patient with a significant intracranial arterial disease. Because you have an artery to artery embolism, that's a no-brainer. You have a ruptured plaque and you have these things going distally. You've thromboembolism of a diseased artery, you already have a stenosed artery, and bang, you have a clot there, and boom, the artery is closed. And of course, you have the hypoperfusion, which is distal to the stenotic artery, which may be, what we call as internal border zone, and you have an external border zone. So external border zone are the typical in the watersheds. You have ACA, MCA, PCA. And you have the internal border zone, which are all those little things, the rosary bead sign that you have, the string of pearl sign, which are there in the central semi-ovale. So, or you can have the atheromatous encroachment on the opening of the ostia of the small little perforating arteries, which actually produce lacunes. So you can have a lacunar stroke and you think that you will never even imagine that it is extracranial carotid artery stenosis, but that happens because of the atheromatous encroachment that happens even in intracranial large artery disease. And of course, you have a mixed pattern, which makes things even more complex. So the natural history of an ICAD, they can present with TIAs and the limb shaking TIAs. Now that's a stroke chameleon. You know the difference between stroke chameleon and a stroke mimic. Now the stroke chameleon resembles something like it is actually a stroke. So here you have a deficit and there is a movement disorder, which obviously resembles something like a seizure. And this has been typically described with a large artery stenosis, both extra and intracranial. And also, obviously, therefore, ICAD can present as a limb shaking TIs. Not very often, but it's been linked more often to ICAD than other ischemic subtypes. Recurrent ischemic strokes, again, a no-brainer. And you have the chronic hypoperfusion syndrome. Nearly 1/3 may just present with a progressive cognitive issues. You have a personality problems. You have a decrease and diminution of their executive function. So one of the varieties of vascular dementias, they just may present with that. And please remember, you have an elderly person, typically, say, a diabetic, they have an autonomic neuropathy, they are prone to postural hypertension, they are on this bunch of medicines which also cause postural hypertension, typically Urimax for prostatism. And if you have an ICAD sitting there, and when there is a syncope, postural hypertension, that's when they're prone to a stroke and also an enhancement of the degree of white matter pathology which can happen there. So chronic hypoperfusion syndrome is a very, very important aspect in this. So the recurrence rate, unfortunately, is really high. People have actually estimated something like almost 4 to 17%. There are more recent studies which said 3 to 8.1% per year, which is still extremely high. The annual mortality, 17%. So almost 1 in 5. So this is big, girls and boys. This is huge. And you know what is known as a stroke-prone state, right? A stroke-prone state is a period where you have the maximum chance of having another stroke. So that is, again, no rocket science to imagine. You have a period which is vulnerable. The plaque is vulnerable. It has not healed. So the greatest chance is in the first few days, and it's supposed to last maximum in the first 3 weeks to 4 weeks, maybe up to 3 months. So it is said that if you've tided over this for a period of 3 months or so, then things have become cold. They've become much, much cooler. So they're not hot anymore. And there's a reason to believe that. And so they say that 50% of the risk is within the 30 days of the index event. And in fact, a lot of prophylaxis, therefore, are based upon this concept There's a lot of evidence to say this, including large RCTs. Now, how do you measure and diagnose? You can do the gold standard is DSA, but you have such advances. In fact, I believe the advancements in stroke, understanding the pathophysiology, dealing with it both acutely and prevention, all this has happened because of this Amazonian advances in neuroimaging. You know, in an acute stroke, 6 minutes flat, whether it is CT based or MR based, you know if it is a stroke, you know if it is a stroke mimic, you know what kind of a stroke, which vessel is blocked, how do you deal with it, what is going to happen if you reperfuse, what is the chance of a bleed if you reperfuse, what is the chance of a stroke recurrence, what's going to happen to the person, what is going to be the stroke outcome. All this thing you can get in 6 minutes flat. These are the kind of advances. And then, of course, there are concepts of course or collaterals. It's amazing how these advances are happening. And I think that is the reason why we have entirely shifted our focus from being nihilistic and, you know, thinking that nothing can happen to one of hope and aggression and this kind of a belief that something can be done for this patient irrespective of what time they come to you, right? So it is CT or MR based. These advances have made these imaging as good as DSA. So you can do this and you'll be able to pick up the ICAD. You also can do a TCD, which has a definite value addition in terms of understanding the embolic phenomena. Remember, that's one of the pathophysiology of the production of a stroke. So you can have a microemboli detection. You can look at a vasomotor reactivity by CO2 challenge, and you can look at luminal narrowing, looking at the velocities. You can do that by anyone who has an expertise in the sonology. So these are representative, the things that I've borrowed from textbook, where this shows. Now, what exactly is this? This is a perforator, okay? Now, so this is a branch atheromatous disease, whereas look at the basilar, terrible. This is all disease, it's irregular, it is, and you do have the imaging now. You can look at a plaque and you can see if it is a plaque, how bad the plaque is. There were some studies which said plaque risk score. Now, in that, you're looking at what is a fibrous cap, how thin it is, what is the amount of, fibrous tissue, you can look at whether there's fat, there is bleeding, there's ulceration, there is some. So these are all the things which makes it vulnerable. Is it likely to go on to produce emboli? Is it likely to bleed and then produce stenosis? What is it likely to do? Or is it thick fibrous cup, lot of muscle there, lot of fibrous tissue there? It is like nicely condensed scarring. There's no scar in the brain. So then it becomes a cold scar. Now, this was available for extracranial. Now, with advances, you're also able to see in intracranial arteries. So, and this is the typical embolic phenomena, right? They're like this shower which go in one artery territory, whereas if they're all over the place, it is cardioembolic. And you can have this internal, what you call the border zone, the internal, okay? That's a border zone, that's a hypoperfusion syndrome. So you can grade the stenosis by, say, we can take a CT angio, you can do it for MR angio. So normal is 0 to 9, mild is less than 30, moderate is up to 70, and severe is 70 and above. And of course, beyond 99 is occlusion. But more important to just looking at a degree of stenosis, just recently, a week ago, someone was saying, yeah, there is ICAD, but the stenosis is not there. No, but that's not the only one I'm interested in. Because for a stroke recurrence is not just the degree of stenosis. You also need to look at the plaque stability and also this huge concept of what's happening to collaterals. How good is the brain preserved? What is the balance of the perfusion that is there beyond the stenosis? It's just like a bank balance, is the brain beyond the stenosis able to sustain further reduction because it's got a good balance or not? That's provided by the collaterals and of course the antegrade flow as well. Now, why, when we talk about ICAD, and I said that go beyond atherosclerosis, you all know about this, that there is a whole lot of pathologies which are arteriopathies intracranially. So besides the atherosclerotic disease, You also have dissections, you have vasculitis, you have RCVCS, and you have Moya-Moya disease or Moya-Moya pattern, which could be part of even atherosclerosis. So all these things look like atherosclerotic disease, but they're not. So you obviously cannot have a one glove fit all approach. You can't treat a vasculitis only with an antiplatelet. Can you? You can't. So therefore, it is important to understand what is causing this arteriopathy. And can you make that out? Yes, you can see it on appearance of vessel imaging. There are definitive criteria as to how to identify these separate pathologies by vessel imaging, the stenosis shape, the vessel distribution, which artery is involved in which pathology, enhancement, the pattern of enhancement will be different, the signal intensity, and of course the other characteristics. So if you look at this table, there is a way to know whether it is atherosclerotic or several other pathologies. And you need to do this when you're talking about an intracranial arteriopathy. Now, in management, we'll quickly go over all these. The best medical treatment, thrombotics, anticoagulants, antiplatelets, the dual antiplatelets, combinations, the newer antiplatelets, and of course, the interventions. Now, the anticoagulants are simple, so I'll deal with that first. Was that all of you know about this, warfarin versus aspirin? What happened? They started with 806 patients, stopped at 569 patients because more people bled with warfarin, right? The inclusion was fine. Bad stenosis ICD, ICAD, and within 90 days of index event. Maybe a little longer, not within 30 days. But what has happened here is that you have more bleeds. They stopped it. But when you looked at the actual, those guys who maintained the therapeutic, what we call as TTR, the time to be in the therapeutic index, or what you call as the typical INR of 2 to 3. When these patients were maintained between INR of 2 to 3, they did great in terms of prevention of ischemic stroke. It was 5% versus those who were less than 2, it was 25%. Similarly, when they maintained between INR 2 and 3, their bleeding risk was just 3.5. If it is beyond 3, it went up to 15. So obviously, when you had a mixed group where INR was all over the place, the end result was it was a negative trial. So therefore, anticoagulants definitely have a role because they definitely had lesser ischemic risk, but offset by more hemorrhages. So then, can we have NOACs on board, please? Yes, lot of interest in this. There's some ongoing trials. I'll come to that. We are also, there's as part of Instruct, there is a couple of trials that are being taken up for ICAD. One of them is actually the role of NOAC because of their the proven efficacy, and I should say proven safety of definitely decrease in intracranial bleed, because in fact that's the greatest USP that NOACs have. Now this is actually a good slide. I always put this up. It is not so much for ICAD, but this for the young girls and boys that, in stroke prophylaxis per se, when you're looking at anticoagulants, whether it is AF or it is with an ICAD where anticoagulants have a role, please remember one thing, that you do nothing, you have a little, you have all the risk in the world. You give one antiplatelet, you have some reduction. You give duat, you have further reduction. You start off with an anticoagulant, you have much, much further reduction. It's just that the anticoagulant should be much safer and you shouldn't offset it by producing more bleeds. So now we're looking at the combination antiplatelets. So let's start with the one which is the most famous is aspirin clopidogrel. Match charisma, I'm not getting into that. They were dismal. So the THALLES trial around the same time did say that when there is a significant artery disease, certainly when you're looking at the microembolic signals, they were far less on performance of TCD when a person was on duat versus single antiplatelets. And this was further borne out in the CHANCE trial, wherein, again, I'm not getting into detail about CHANCE, wherein the most important thing here was that it was a duat given in the first 3 weeks. That is, they started off in the stroke-prone state, stopped when at the end of 3 months. So they didn't go on like a match. Therefore, you could do it. But then what had happened in chance is that, so in chance also you had a separate group of ICAD. And they found that even in ICAD, the same kind of benefit with the duad persisted. Okay, so keep that in mind. And another important thing which emanated in chance is that that percentage who had the CYP2, C19 loss of functionality, who did not do well. So if you're genetically not going to respond to clopidogrel, look at another antiplatelet which should be in combination with aspirin, and that's when ticagrelor did come in. So therefore, although limitations of chance was that it was predominantly in Asian population, and one of the limitations they said is this is the group where you had a lot of large vessel, isn't it? Right? So, but that's what we're talking about. We're talking about predominantly ICAD as a stroke subtype. Okay, so there is a point. Now, the point trial came in to sort of look into the limitations of the chance. They looked at another ethnic population. They had a more mixed group, and they found the same results as far as a minor stroke is concerned. And when you given double antiplatelets in the first 3 weeks, you did better. It's a beautiful meta-analysis Dr. Prasad had published in BMJ in 2018. And here as well, the story is in favor of giving a duad, certainly, and where? Till 21 days. The second combination, aspirin diprodamol, we're not going to get into this because nothing was for the intracranial pathology. This was predominantly for the mixed group of, in general, strokes per se. Then we have aspirin silastazole, big thing. This is something which we need to look at. Now, silastazole is, I think, is giving a serious competition. As high time, as personally, I think this should come on board as with a level 1 evidence along with aspirin and clopidogrel. Load of evidence which is coming up, which has come for some time now. This is there, in fact, in the guidelines of Japan. And you have this silastazole as an alternative to aspirin, and with a lower bleeding risk. Yes, it's got a little bit of, a relationship with diprodamol. So you do have headache as a significant side effect, but it's otherwise is a great drug. So it's non-inferior to aspirin, fewer hemorrhagic events, and those conditions where people start bleeding with even with 50 milligrams of aspirin and leave alone clopidogrel, silastazole comes on board, and the dose is 100 BD. And then we have these combinations which have come up. And this was again a Japanese trial. And they again looked at the combination versus just oral aspirin alone. And they looked at it and they found that the dual therapy was far, far greater in terms of efficacy. And the life-threatening bleeding was much less in this combination of aspirin with silastazole or clopidogrel. So this combination was doing good. And this is something which you should, keep a lookout for. So therefore, in ICAD, the Korean group looked at the combination of silastazole with aspirin or aspirin with placebo in the TOS study, where they actually looked at the progression of ICAD using just an MR angiography. It was a short interval study, and they found the difference in progression was huge. It was just about 7.8% in the combination versus something like 24% in the single platelet. Obviously, this was not a clinical study. They had no clinical, outcome parameters there. It was just an MRA study. Buoyed by this, they went on to TOS2, wherein they looked at both the combinations. They looked at silastazole, clopidogrel versus aspirin and clopidogrel. And in this, silastazole with clopidogrel fared a trifle better. Again, look at this, that this is a progression of ICAD per se and not so much the clinical parameters. And then we have aspirin ticagrelor. Now, remember, ticagrelor is, again, a relative of clopidogrel. Its USP is that those guys who have a genetic predilection of being non-responsive to clopidogrel can benefit with ticagrelor because it's an active ingredient. The SOCRATES trial was a negative trial. It was designed well and very similar to the THALLES trial, which came in much later and just got released. It's just got published. and also presented in the World Stroke Congress recently. But then, so they went on to the THALLES trial, wherein it was 11,000 patients. Actually, our center was also part of THALLES trial. And it was a difficult trial in the sense you needed patients who had to be randomized and given the drug within the first 24 hours, who were not thrombolized, who didn't undergo the endovascular the treatment, and who didn't have to go on to carotid endarterectomy, but who had a large artery disease and an ABCD of more than at least 6. That is the very, very high atherosclerotic disease, a high chance of recurrence. So in these patients, ultimately what did they find? That the risk of composite stroke or death within 30 days was lower with this combination than aspirin alone. So in a high load of atherosclerotic disease, this combination is proving to be safer as well as seem to be beneficial. There was no difference significantly in disability at the end of 3 months, and again, THALLES is something which predominantly had an Asian population. Large number of Asian countries took part in this, although it was by Clay, Johnston monitored, and then Peary, Amarenko was the other person who was there from Europe monitoring it. Large amount of Asians in THALLES study. Waterfaxor is a selective antagonist of protease activator receptor 1, and this is in active research. And you have this triple drugs, aspirin, clopidogrel, diprodamol. Tell me which was the trial? TARDIS. It was negative. Forget about it. We are not going to talk about that. And then we have the combination of these two with stenting. The combination of antiplatelet with anticoagulants I'll come to a little later. So that brings us to stenting. That is percutaneous transluminal angioplasty with stenting. So the first one was a SAMMPRIS trial. You know, the wingspan stent, you know, that was FDA approved in which year? 2005. You know, and then came the SAMMPRIS trial, and people thought that it will do great. But the fact is that the aggressive medical management, as you all know, had really become aggressive by SAMMPRIS as compared to Vaucet. And so you had a personalized lifestyle, you know, they had a program wherein people would call up at periodic intervals and tell them to stop smoking, you know, have you taken the medication, safer and more effective and less side effects. So it was not that you should not open a blocked artery. It's the way you're doing it. No, that needed to be safer. That's where it fell flat. So the results of SAMMPRIS trial was not good. So medical management was superior. But then please remember that was that medical management and that was that stent. So obviously things change. So this is the intervent. This was that procedure that I'd used, the lifestyle modification, and then very, very aggressive, intrusive, monitoring about sticking to the lifestyle modification. So the risk factor management becomes a cornerstone with or without stenting. And as we said before, hypertension, diabetes, dyslipidemia, cigarette smoking, no brainer. You need them to be under control. The blood pressure control, though, is interesting because you don't have one measure. It is actually a J-shaped curve. When you have a very low normal, the recurrence is supposed to be 21%. So don't get it to too normal. Normal to high normal, 120 to 130, the recurrence was 10.7. 140 to 159, 11.4%. So this is a sweet spot. Okay, so something like 120 to maybe 140, 150 maximum. This seems to be the sweet spot of maintaining the blood pressure. Not too low, not high, definitely not high, because going by more than 160, very, very high risk, 40% risk of a recurrence of a stroke. So what is END? END is early neurological deterioration. The concepts of END are also changing. We have a lot of, the END also is determined by what kind of a stroke subtype and what kind of an intervention you've done in an acute stroke with that kind of a subtype. Okay, if you have a left ventricular thrombus and you've thrombolized, the end is different. So said that the end in patients with ICAD is supposed to be caused by the perfusion defect in the territory of stenosed artery. So please remember this, that end in ICAD is different from end in other stroke subtypes. So the lipid management, a lot of focus on the statin use. So here again, the guidelines do recommend the use of high dose statins. And because of the indirect evidence that effects of statin had historical controls of VACID and SAMMPRIS trial, the Korean and Chinese trials actually looked at imaging evidence. You give a lot of statins and look what's happening, and in various either the imaging biomarkers or blood biomarkers, and look at the progression. And there is an ongoing study, the Treat Stroke to Target, wherein you are looking at the occurrence of a recurrence of an ischemic event by controlling the LL cholesterol 100 plus or minus 10 group versus less than 70 milligrams per deciliter group. And there are also these imaging studies. So there is one stamina MRI study where you're looking at high resolution MRI and intensive statin therapy in statin naive symptomatic patients with TICAD, and then you're also looking at beyond statins, you have other ways of decreasing cholesterol and the bad lipids. So there is another study, which is the Reduce It, where you're looking at the intervention with the ecoserpentithiol intervention. And you also have the PCSK9. Now, this is a new kid on the block, and a lot of literature focusing this molecule, these agents as something where statins don't help. Get into this and look at the atherosclerosis progression. The inflammatory cascade is another aspect. Atherosclerosis progression has intricately inflammatory part into it. Now, these guys definitely act on the endothelium. So people have looked at simple molecules like HCRP, interleukin-6. They are universal molecules, so they're the end result. But people are looking into this. There's a CANTOS trial where people have used canakinumab, but this definitely decreased the ischemic events, but caused a lot of sepsis. So this was out. There's an ongoing, the colchicine trial. Interestingly, girls and boys, colchicine low dose is also coming for COVID management. These are, because this is kind of the end event of any insult, I suppose. So people have actually been looking into these as well. Now come the interesting aspects of combining stuff. The COMPASS trial is a huge trial in atherosclerotic vascular disease, including peripheral artery disease. And what are they doing? They're combining rivaroxaban with an antiplatelet, a low dose of rivaroxaban, the NEWAC, with a low dose of aspirin. And in fact, they stopped it early because there was a superiority with rivaroxaban with aspirin over a period of follow-up, and hardly much hemorrhage to mood. Okay. And the conclusion in the COMPASS results were that when you give low dose rivaroxaban, just 5 milligrams PD, and aspirin, again low dose 75, is a therapeutic option for prevention of patients with atherosclerosis, right? But the ongoing trial now is the one in ICAD, rivaroxaban with aspirin. This is a phase 3 trial, and this probably will be out December 2022. Interesting. Now, the advances is also attuned to the improved assessment that we have of etiology and the stroke mechanisms in ICAD, the high resolution vessel wall imaging with MRI and the biomarkers. Please, this is what has actually been galvanized a lot of action in, being aggressive towards ICAD. We know about the percutaneous transcranial angioplasty and stenting. SAMMPRIS, VISIT, tragedy, pathetic, forget about them. The wheel trial, though, subsequent to that, when we actually have a post-market surveillance of the wingspan stent system, this was great because the low complication rate, just about 2.6%. Why? Because of increased operator experience, expertise, and differences in techniques. Stenting after 7 days. Don't try and stent when the plaque is extremely vulnerable. More rigorous operator selection. Just don't go over the board and say with 1 month training, let them go and do it. You can't. You have to pick and choose. And, inclusion of patients with more than 2 strokes. Don't be foolhardy. 1 stroke, don't go into the war zone. So you need to choose your patients well, choose the interventionalist well, choose the place you're going to practice this well. A lot of selection criteria there. The Chinese stenting registry is again a success story. So this has been published. This is still ongoing. And there, after the procedure, you had a very, very low rate of complications. Again, they said maybe better experience. The Chinese have a lot of ICAT, have a lot of experience, they have the bulk of patients, maybe younger patient population. And again, they tried to stabilize a plaque. So they took the patients beyond 7 days. There's something called a slow-plowing effect. Now this happens, and this is one of the reasons in SAMMPRIS, you know, a lot of perforator, problems after the procedure, because, when you put in the gadget and you're pushing the atherosclerotic material into this little, the branch occlusions, those little ostia will also get occluded. That's called the snow-plowing effect. So the current indications for angioplasty and stenting is that there is age, but I know age is just a number. I'm sure this is going to change. Definitely more than 2 strokes despite best medical management. Most recent stroke should be more than 7 days. 70 to 90% stenosis and MRS has to be less than 3. You need someone who's stable enough and who can improve further. There's a little concept of remote limb ischemic conditioning.
Gentle reminder for the time, ma'am.
Yeah. So,
thank you.
Okay. Sorry. So this remote limb ischemic conditioning is something like a homeopathy. You keep on giving a little bit of ischemia there. They produce a lot of nitrates into bloodstream and probably will help. Surgery is ECIC bypass, and ERS is an ongoing trial for ERAS or extradural arteriosus, which have all been in there as alternatives in those patients we need to reperfuse and revascularize. But when can we quantify the recurrence risk of symptomatic ICAD? In general, it's very, very high. And they found that besides this extremely, monitored trials, the real world recurrence is even higher, almost 20%. So the risk is real. And the predictors of recurrence is degree of stenosis, early enrollment, increased blood pressure, poor collaterals, And so the last 2-3 slides, Veritas is vertebro-basilar flow evaluation risk of TI and stroke study, which is a quantitative MRA to assess the blood flow across a basilar artery. And we use ASL very freely for this. And Myriad are the mechanisms of early recurrence in ICAD, and which is looking into vasomotor reactivity, the evidence of hits, and also using the diffusion imaging. Rapid is something which a lot of us have been in use. It's still to come in AIIMS. So you can, using these markers, you can risk stratify the ICAD patients and also use biomarkers for the same. And then, these are all the trials which have been done, ECIC, WASET, SAMMPRIS, VISIT. And then these are some of these ongoing trials. This is a take-home thing, wherein when can you do? You use a double antiplatelets, aspirin, clopidogrel. There's an ongoing study now. We are using it beyond 3 months. There's a study which would compare 3 months to 1 year. Study comparing antiplatelet to NOAC. Now TICAGRELOR has come on board. So those guys who don't respond to clopidogrel can go on to TICAGRELOR. Statin and other methods, if statins are not on board, BP, lifestyle, angioplasty, stenting with definitive predictors. So all these, and one thing about this is subaximal angioplasty without stenting is another procedure which is being done so that you're not really, not getting into this branch atheromatous strokes in such thing. But most important is that you probably will summarize and say for an ICAD management, you need a personalized and precise medicine. And looking into all these, the imaging, the lab, look at what is causing stroke in that individual and choose that kind of a stroke prophylaxis in management of an ICAD. That is it. So I think these slides should be there. You all can freely download them and use them at will. Thank you for overstepping the time.